Hello, everyone, and welcome to another lecture of pulmonary medicine. Today, we are going to talk about an important lecture, which is VTE. Specifically, we are going to talk about pulmonary embolism. Now, we all know about the pulmonary embolism, where it starts from the deep vein thrombosis and it transfers through the inferior vena cava into the right heart, and from the right heart into the pulmonary artery, which leads to lung infarction. But today we're gonna delve more into this topic. We're gonna know almost every aspect of this disease and how to use this information to pass the exams, whether they are for medical students or for the internal medicine doctors. I think it's gonna be helpful. What's VTE? VTE is a chronic condition in which the blood clots mostly in the deep veins and possibly leading to pulmonary embolism. Pulmonary embolism can be acute or chronic, but most of the cases that occur in the medical field are of a chronic condition. All right, and we have to know that the most veins affected are the deep veins. I mean, it's not impossible for it to occur in the superficial veins, but the deep veins are more affected, especially the proximal ones, starting from the popliteal and above. All right. Uh, since it's a deep vein thrombosis, can occur in any vein, actually, like any deep vein, like renal, subclavian, and also in these uncommon sites like the hepatic, portal, or the splenic veins. The pathophysiology of pulmonary embolism. Now we have to understand that pulmonary embolism affects mostly the right heart. All right, it can lead to right heart strain, as we will know from this diagram. You can see that the pulmonary embolism leads to a right ventricular volume and pressure overload, which leads to right ventricular dilatation, and there is a decreased right ventricular cardiac output, and that leads to interventricular septal deviation to the left ventricle. Now, this is an important point, as we will see in the echocardiography, that this septal deviation is very helpful in the diagnosis, also in CT scans, in the diagnosis of this pathology. All right. And then this deviation can lead to decreased left ventricular cardiac output and systemic hypotension. That's the mechanism of shock or instability of severe cases of pulmonary embolism. And then there is an decreased oxygen supply to the right ventricle. Now, this pressure and overload can also lead to increased wall tension, which would increase the oxygen demand. Now, increased oxygen demand and decreased oxygen supply, that's a right heart ischemia, which can also lead to infarction. And this ischemia and infarction can lead to or potentiates the right ventricular dilatation and induces this kind of vicious cycle. Now, to the lung, the most pathology of the lung is the ventilation perfusion mismatch, right? And in some chronic cases can lead to a lung ischemia, all right? Now, chronic thromboembolic pulmonary hypertension. This is a common chronic complication from pulmonary embolism, from chronic pulmonary embolism. As you can see here, the lung infarction, also talk about this in the chest x-rays. It's known as the Hampton substance, not that specific or sensitive, but it occurs due to the persistent obstruction from the thrombus itself or due to a persistent vasoconstrictor response. All right. Now, pulmonary hypertension can lead to secondary vessel arteriopathies. All right. As you can see here, it can be to wall intimal thickening and hypertrophy. It can lead to microthrombi due to the vasoconstriction and the small diameter vessels, and to the other pathologies as well. Now, fear cause triad. Now, this is the most important thing regarding the risk factors for pulmonary embolism or any venous thromboembolism, such as DVT, of course. These consist of the three elements, which are blood stasis, endothelial injury, and hypercoagulability. Now, anything that leads to blood stasis, or you just sitting up and not moving, it can lead to blood stasis, such as embolization, hospitalization, and spinal cord injury, leading to paresis or paralysis. Pregnancy, obesity, varicose veins, these can cause blood stasis. Now, May-Turner syndrome is a compression. As we know, in the left side, there is a compression of the right common iliac artery compressing the left common iliac vein. Now, this compression, which occurs on the left side, usually leads to this area being more susceptible to being a place where thrombus occurs, all right, known as May-Thurner syndrome. Endothelial injury. Now, the most common thing is orthopedics and joint trauma and surgeries, prior DVTs or PEs, an injury to the vessel through a central venous catheterization, and other vascular problems as well. A hypercoagulability problem can occur in old age with cancer, diabetes mellitus, and obesity. Hormone replacement therapies are a very common cause of hypercoagulability, and pregnancy in itself is a hypercoagulability state. Other thrombophilias and hypercoagulability disorders, such as factor V Leiden and prothrombin mutations, protein CS and antithrombin 3 deficiencies, the antiphospholipid syndrome, polycythemia vera, paroxysmal nocturnal hematuria, all this can lead to increased thrombosis. Now, sepsis is also a cause of hypercoagulability. As we know these days, with the COVID-19 disease, now it's also become a risk factor, a common risk factor nowadays, actually, that leads to a hypercoagulability and possibly a PE, right? And also, we can't forget dehydration and nephrotic syndrome. Other risk factors that are has been discovered recently that also can lead to VTEs, such as congestive heart failure, AC acute coronary syndromes, strokes, any peripheral arterial disease, COPD, inflammatory bowel disease. These can be tricky ones, right? The clinical picture. Now, none of these is specific or sensitive for the PE. All right, the patient can present with the shortness of breath, tachycardia, tachypnea, pleuritic chest pain. I mean, if we're lucky, we can see like some cough, hemoptysis, wheezing. That at least it will tell us that the problem is in the lung. A PE can present with fever, any sign or symptom of DVT, hypotension, and syncope if it's massive or supermassive in size. Now, the tricky part about this is that you can spot like a lung problem here. We see shortness of breath, we see tachycardia, tachypnea. Anyways, we have to do chest X-ray. That you always the first step in the management of PEs or any chest problem is we start with the chest X-ray. If the chest X-ray is normal, that means the lung is normal. Now, where is the pathology? Maybe we think about the pulmonary artery. All right. Regarding complications, the patient will sometimes will come with hemodynamic instability, like we talked here, like hypotension, for example. Now, this is usually due to the right ventricular dysfunction that occurs as we talked about this in the pathology. Sometimes it can be so severe that it leads to obstructive shock, arrhythmias, and cor pulmonale. Chronic thromboembolic pulmonary hypertension, defined as pulmonary artery pressure more than 25 millimeter mercury for at least 6 months. All right. Sudden death can occur in very large or supermassive PEs. All right, this can lead to a cardiac arrest and death. Now, this is the extent of the pulmonary embolism. 5% they can be massive or supermassive PEs. These usually there's hypotension and cardiogenic shocks and arrest, and more likely to develop a cardiopulmonary failure with the systolic pressure of less than 90. Submassive 25%. Usually the patient is stable, but there is a right ventricular dysfunction with more risks of other complications later on. PE with normal blood pressure and right ventricular function. This is the most common PEs. All right. There's no instability. The patient is stable and there is normal right ventricular function. Usually these are chronic PEs. All right. They have good prognosis, especially with anticoagulation. The Wels criteria. We all know the Wels criteria, and you have to know that the Wels criteria for DVT is different from that for PEs. You don't confuse that. Today's topic is pulmonary embolism, of course, so we're going to talk only about the Wels criteria for PE. Now, of course, as any criteria, there are points assigned, and then you have to calculate these points, and you give a total score or pretest probability. Now, this is the idea about the Wels criteria. We have to measure the pretest probability. Like before we even investigate this patient and we do tests, we have to know what's the probability of these symptoms or of this patient that he has PE. All right, this is going to be very helpful in the management of the patient, right, or in the diagnosis of this patient specifically. So, signs and symptoms of DVT. This gives 3 points. Now, the second one is very important one. Like as we talked about, the patient usually has normal chest X-ray, and from the history of this patient, he might not have any cardiac or pulmonary problem, no COPD, no congestive heart failure. You check the past history, he's fine. Now, there's no alternative diagnosis for these symptoms that he presented with. All right. Now, this in itself gives us 3 points. All right. The unlikely or the less likely probability that this patient has any other disease rather than PE in itself gives us 3 points. An immobile patient for at least 3 days or surgery within the last 4 weeks gives 1.5 points. A heart rate over 100 gives 1.5. Prior DVT or PE gives 1.5. And then there's the small ones that, like pregnancy, as we talked about, increase the hypercoagulability, and also hemoptysis can be a sign of PE. So these ones gives 1 point. You calculate the total score, and you grade as high or intermediate or low probability, as you can see here with these numbers. Now, there's an easier way to do this, and you just give a point of 4. Like if it's more than 4 points, this likely PE. All right, it's not based on like here a probability, but it's only binary. Like it's likely or unlikely. If more than 4, it's likely to be PE. If 4 or less, it's unlikely to be PE. And then there is the simplified Wels criteria, which we rarely use. It gives 1 point for each one of these. Okay, and then you calculate the score. A score of more than 1 is a likely of PE. All right. We usually use this one with a 4 as a cutoff. If it's more than 4, it's PE. If less than 4, it's unlikely to, or 4, it's less unlikely to be PE. Okay. Now, what's the PERC criteria? It's pulmonary embolism rule out criteria. Now, you rule out the possibility of this being PE with these criteria, as you can see. Small age, no tachycardia, normal saturation, no hemoptysis, no estrogen use, no prior VTEs, no hospitalization or surgery lately, no unilateral, no DVT, basically. So, if these criteria, all of them apply to the patient, that we calculated a Wels criteria with low risk probability or unlikely to be PE, right? A patient with unlikely PE, for example, with a 4 or 3 total score, we do the rule out criteria. If this all applies, this patient is ruled out for PE, all right? And we don't have to do the D-dimer. Now, this is usually used in the emergency department, as it can be easy to do, especially if it's hard or possible to do a D-dimer test, or if it's unavailable. Anyway, this is not like in the exam, it's just in real life, all right? Another thing we're going to talk about is the pulmonary embolism severity index, the PESI score. Now, this is important. The Wels criteria we talked about before, it determines the pretest probability. If you want to know if this patient has PE or not. But this criteria, the PESI score, it's used to determine the severity or the prognosis of this patient. Now, for example, if we already know that like this patient we diagnosed with PE. Now, this score tells us what's the likely of this patient to die in the next 30 days. Okay, it calculates the 30-day mortality rate. All right. Now, there's the PESI score, and this is a simplified PESI score. We're gonna use the simplified one, of course. Each one of these has 1 point. As you can see, you calculate this and you determine these points. If it's low risk, 0, now you have a almost like 1%, 1 to 2% mortality rate, right? There's about 2% or 1% risk that you're gonna die in the next 30 days. Now this is a low risk, obviously. If it's 1 or above, the score is 1 or above, right? Now there's about 10% risk that this patient is gonna die in next 30 days. Especially the first 2 weeks. The first 2 weeks are the most critical time, the early time for this PE patient. We're gonna use this basis score a lot in determining like especially for the intermediate risk patients, like which ones, like if this is so severe, we're gonna like resuscitate and use reperfusion methods. If it's low, the severity is mild, all right, or low severity index, we're gonna use anticoagulation, of course. But what about the intermediate? What's between? How are we gonna decide the treatment and the risk of these patients? Now this can be a big variable between patients, so this is gonna be helpful. Diagnostic tests, we're gonna talk about these diagnostic tests and how they are used, but then we're gonna talk about the schemes and how we approach the PE patient. All right. Now first we're gonna talk about these separately. We don't do all of them, of course, but we will mention what can we see and what can we find. All right. All right. Just X-ray. Now this is the first step, obviously, as we talked about. Like you say, a clinically abnormal lung with normal chest X-ray. It means that the patient clinically presents with a symptom. All right. If we're lucky, we'll see like dyspnea, we'll see like tachypnea. Tachycardia is more, maybe might be a little more than, or more specific than the others, but it's still very, very non-specific. All right. Normal chest X-ray, you suspect a VTE. All right. Now, as you can see, normal chest X-ray is the most common, but we also can see non-specific pathologies, like, for example, we can see bibasilar atelectasis, we can see Hampton's hump, a wedge shape prefer wedge lung infarction, as we talked about before, and asymmetrical pleural effusion. Fleischner sign is a large and sharp pulmonary artery, as you can see here. This looks like a hilar mass, all right? But when they assessed this patient and then they did the CT for this CTPA for this patient, it turned out that this patient has large PEs that affected both pulmonary arteries, right and left, and led to this large and sharpening of the pulmonary artery branches. Westmark sign, a decreased vascular markings downstream of the embolus, like you see oligemia in the peripheries, for example, or in the site of the clot, all right, peripheral to the clot, you're gonna see this oligemia. A cardiomegaly, as you can see in these both, this is a Hampton's hump, wedge shape, usually in the peripheral side or the costophrenic also. And as you can see, both of these have cardiomegaly, as you can see, due to the right ventricular strain. A CTPA. Now this what used to be a spiral CT with contrast. Now every CTPA has a contrast. All right. So we have to watch or assess the patient before doing this. The contrast is contraindicated in allergies or renal impairment, as we know. And what you're gonna see is we're gonna see a filling defect in the shape of, as you can see here in this anatomy, you see the pulmonary artery, all right, and with its right and left branches, all right. Here to the right of it, you can see the ascending aorta, all right. So this is a filling defect inside the contrasted, all right, stream here. You can see the pulmonary artery, and this clot affects, or this thrombus affects both branches, and in a saddle shape known as saddle embolism. All right. It doesn't have to be in this shape. It can be any segmental or subsegmental, as you can see here. Here, a filling defect inside a contrasted area. Here, a filling defect inside the contrasted area. These are the acute ones. Now, these are the chronic manifestation that we can see. You can see like an increased diameter of the pulmonary artery. You can see a right ventricular enlargement and septal deviation, as you can see here. Now, we all know that the left ventricle is larger than the right ventricle, but in the case of right heart strain and right ventricular dysfunction and leading to increased right ventricular diameter of more than 1. So as you can see here, the right ventricle is larger than the left. And of course, we can see the changes that occur with chronic thromboembolic pulmonary hypertension. We talked about the thickening of the wall. Now, this is not the clot. All right, this is not the clot. You can see this is like it looks like a filling defect, and in the middle this is a contrast. Now, this is not a filling defect. This is the increase or thickening of the intimal part of the pulmonary artery branch. All right. If a CTPA is contracting for any reason, we tend to use VQ scans. All right, they're not done a lot. They have high radiation, more than the CTPA. But for pregnant women, this is usually preferred than CTPA, because CTPA can sometimes affect the pregnant women's breast tissues, which become more sensitive to radiation. So this might be a better choice in pregnant women, and also in those with contraindication to CT. Anyhow, or contrast specifically. Anyhow, this is not a good test. It has 15% of being false, either false negative or false positive. Now, usually it requires the normal chest X-ray. Now, why is that? Because you need a high probability that this patient will have he has PE. So if this chest X-ray is abnormal for any reason, for example, COPD or any lung disease, any atelectasis, all right, any problem that affects the ventilation perfusion mismatch we talk about in the pulmonary principles lectures. Now, this is going to be a problem for the sensitivity of this scan. So a perfusion scan, we do usually two: perfusion and ventilation scan. A perfusion scan can be compared to either the ventilation scan or the chest X-ray opacity. Sometimes in pregnancy, we do only perfusion scan and compare it to not the ventilation scan, but to the chest X-ray, because it reduces the radiation a bit with not doing the ventilation scan. Now this perfusion defect, we're going to see a perfusion defect. All right, we compare it, for example, to the ventilation scan or the chest X-ray opacity, and if it's larger than the other one, now this is a mismatch. For example, the perfusion scan is larger than a ventilation defect. This is a mismatch. But if the perfusion defect equals or less than the opacity or the ventilation defect, now this is a match and not valid to say anything about it. So, for example, this one, we have ventilation scans and perfusion, or the Q is usually is abbreviated for quotient. This is ventilation quotient, so known as ventilation perfusion scan. All right. As you can see here, for example, you have many spots, like it's like a camera. You picture the lung from different places. You look usually at the perfusion. You try to spot, like for example, in this posterior position, there is no clear defect. But in this position, you can see a clear defect. Here, there's a clear defect in perfusion. This is the heart. This normal, usually maybe here a defect, maybe here. So there's a defect. There are clear defects in the perfusion. All right, radiation scans, and you compare it to the same picture in the ventilation scan. For example, here you can compare it to this one. You see the ventilation is normal, but here the defect is larger. The perfusion defect is larger than the perfusion one. Now this is clearly a high probability PE. Here, also known like for example, like the more this defect, the perfusion defect, all right, with normal ventilation, this is what we talked about, and we said this is a dead space, all right. It doesn't have to be a perfect dead space. It's usually a mismatch, all right. But now in this case, you can say this is a high probability PE. And the other one, as you can see, maybe we compare this ventilation. Here is a ventilation defect we see, but the perfusion is normal. Now this is the opposite of this one. Like you have abnormal ventilation, but normal perfusion. Clearly, this is not PE. All right, this is what's known as physiologic shunt. A physiologic shunt can usually occur due to a severe obstructive problem. For example, maybe COPD. Here is another site. You can see the ventilation defect, and we compare it to the same one with perfusion. The perfusion is normal, so this is not PE. And now echocardiography. We, as we can see here, there are many things that we can spot the effect of pulmonary embolism in the echocardiography, but the echocardiography is one of these parameters that's really important to tell us the severity of a patient with PE. For example, we talked about the Wels criteria. We said this one is for the pre-test probability, this is for diagnosis of PE. But we talked about the PESI score also when we said this is more about the prognosis or the severity of PE. All right. There are other things that can determine and tell us more about the severity, especially the echocardiography. Echocardiography, and the third one is biomarkers. They are important in telling us like what's the prognosis, what's the severity of this patient. As you can see here, you see an enlargement of the right ventricle, a deviation, a ventricular to left ventricular ratio more than 1. We talked about this before, all right? And you're gonna see like a sign called McConnell's sign, an apical hyperkinesis with free wall, lateral free wall hypokinesis. As you can see in this echo, you see the apical part is moving and the free wall barely moves. This is McConnell sign. It's not that specific, it's not that sensitive, but it can be one of these signs. All right. A flattening of the interventricular septum and a D-shaped left ventricle, as you can see here. A distended inferior vena cava with diminished inspiratory collapsibility. A tricuspid regurgitation can be one of the complications of PE and increased pulmonary artery pressure. As you can see here, you can see the tricuspid regurgitation with echo. Seeing the thrombus itself in the right chamber in itself is a very bad prognostic sign that this patient like is not gonna end up well. The risk of death is very high. All right. And this is the M mode on which you calculate the decreased tricuspid annular systolic excursion. Usually, it's done when you calculate this area from the apex, heart apex, to the annulus of the tricuspid, used to measure the tricuspid regurgitation. Usually, if less than 60 millimeter, this altitude, it's a good sign for tricuspid regurg. All right. Anyways, EKGs, they're not used in the diagnosis. They're not used to diagnose PEs, but they are very important. All right, we have to know that EKGs that PEs can present with abnormal EKGs. Now this is very important. All right, why is that? Because, for example, let's say there comes a patient in the emergency department and you see a T-wave inversion in the anteroseptal leads. All right, now immediately you're gonna think of what? An acute coronary syndrome. All right, you're gonna think this is ischemia in the anteroseptal ischemia. All right, let's assume that you activate the cath and the cath lab, and this patient turns out that he doesn't have any coronary uh, syndrome. Are you going to send this patient back home? No. We have to know, like, this pathology, where did it come from? Now, there are things that, more specific than the others. For example, an anteroseptal, it can be either one, but they say that anteroseptal with inferior together, anteroseptal and inferior T-wave inversion, this can be very specific for PE. All right, a right axis deviation, right bundle branch block. These big problems. They can't be like normal. If you see this patient and it doesn't have any one of these, for example, ACS, aortic dissection, pericarditis, you have to rule out the possibility of it being pulmonary embolism. Why is that? As you can see, this patient has only T-wave inversion in the anteroseptal leads. Now, this patient was unluckily sent back home because they did catheterization to the heart, and it turned out that he doesn't have any acute coronary syndrome. But guess what? In a few days, he dies because this patient has a large pulmonary embolism. All right. Now, all these, as you can see, they're not specific. You can see like a very classic S1, Q3, T3, like S wave in the lead one, Q wave in lead 3, and T wave inversion. It doesn't have to be this way. It can be only S1. It can be S1 Q2. It can be only T3. Any one of these. They're not specific. Right axis deviation, extreme right axis deviation, ST changes. Tachycardia is the common. The tachycardia, as we said, is one of the clinical findings you can see in PE. It doesn't have to be present, of course, but if you find one, a supraventricular or ventricular tachycardia, you have to put PE in the differential diagnosis, and not only do this mistake of telling that a coronary acute coronary syndrome is the only possibility. You have to rule out all of these possibilities for abnormal non-specific EKG changes. Now, this is one Q3 T3. Duplex ultrasonography. It's the same thing as CTPA for PE. This is for DVT. All right. When you say, like, in the criteria or on the algorithms, we do imaging. If you're looking for PE, you do CTPA. If you're looking for the DVT, you do duplex ultrasonic compression ultrasonography. Now, this is the standard of care for DVT. We're gonna talk about this, and it's enough to start anticoagulation. We're gonna talk about this in the cardiovascular system. Angiography, it's the most accurate, of course, but let's be realistic. It's never gonna be done. Right? It's not the gold standard anymore. It has 1% mortality risk, so it can lead to death. It's not a good choice. The D dimer. Now, this is a very important one. Now, we all know the D dimer is a degradation product of cross-linked fibrin. So when we use this test, we use this test to rule out PEs. Not just to rule out PEs, but in those who are unlikely, or the possibility of the pretest probability is low or intermediate risk probabilities of it being PE. For example, if it's less than or equal to 4 with Wels criteria, as we talked about, PE unlikely, as you can see here. Also, if the probability or the probability, if you calculate the probability with low, intermediate, and high risk, if it's low or intermediate risk probability, we can also use the D dimer to rule out and not to rule in a PE. All right, it has good negative predictive values in these patients, in patients with low probability of being a PE. Why is that? Because this test is highly sensitive. Highly sensitive, that we know this mnemonic snout. The sensitive test rules out disease, but not specific spin. The specific tests, they rule in. Now, this is not specific, and it's extremely sensitive. So it's, again, used to rule out PEs in low probability patients. The cutoff value is 500 micrograms per liter. If it's less, PE is excluded. If it's more than that, it's not diagnostic, of course. D dimer increases in many conditions, in almost like any inflammatory, any infectious, any of these processes, any like even in pregnancy, the D dimer is useless in pregnant women because it's elevated there. So we have after that to do imaging. We do CTPA. The biomarkers. Now this is the third one used to tell the prognosis of the patient, especially the troponin, the BMP. These are the biomarkers used with PEs. ABGs, they're not good. I mean, you can see like decreased maybe oxygen pressure with increased AA gradient. Some patients, they don't have a decreased PaO2. PCO2, same thing with the carbon dioxide, maybe elevated, maybe decreased. It's not going to be any of help. All right. And it's not used. Oxygen level, PCO2 is not used to tell the prognosis of this patient. It doesn't say like this patient has a low oxygen pressure, then this patient is in a bad condition. No, it doesn't have to be. Maybe some patients are like, for example, they can be like really in a bad condition, all right, and a very high risk to death, but with maybe minimal change in PaO2, all right. The pulmonary function test, just maybe you see this when they say like isolated decreased DLCO with normal spirometry, normal lung function tests. Now this can be one, like any vascular lung disease can lead to this isolated decreased DLCO. Hypercoagulability workup, like when we do these things like the JAK2 mutations, the antithrombin, anticardiolipin tests, we don't do these in all patients. We only do this in special cases. For example, like a recurrent thromboembolic event, a young patient, or with a family history of hypercoagulability disorder, a DVT in unusual site, like a hepatic or portal or even splenic veins, thrombosis. Now these ones, maybe you think of these kind of diseases. You do the JAK2 kinase, JAK2 mutations to see if this a polycythemia vera, for example, these like essential thrombocythemia diseases, a CD55, CD59 for like PNH, paroxysmal nocturnal hematuria, protein C and S deficiencies, antithrombin deficiency, the anticardiolipin and PTT for antiphospholipid syndrome. All right, assessment and management. Now this is the important part about this lecture. Why is that? Before we talk about the assessment and management, maybe we give a note about pulmonary embolism in pregnancy. Like it's really hard because we can't use the regular tests like the D dimer in pregnancy. It gives false positive. It's elevated in all pregnant women. It's hard to diagnose. Actually, the women with pregnant women, they have dyspnea. It can be masked. The dyspnea to do PE can be masked because it is it's one of the risk factors for PEs. Of course, it has high mortality rate. The first initial test is either chest X-ray or duplex ultrasonography to look for a DVT. These good initial tests to do. A normal chest X-ray lets us prefer maybe ventilation perfusion scan, especially if it's only perfusion. Why is that? Because we talked about the CTPA, that it has like high radiation for the breast mass of breast tissue of pregnant women. But if the chest X-ray is abnormal, this is not going to be, the VQ is not going to be valid. So maybe we do CTPA and accept the small risk of radiation, right? Anticoagulation, we're going to talk about this, that with pregnant women, we can't use the warfarin, we can't use the new anticoagulants, DOACs. We only use the low molecular weight heparin for at least 3 months and then until 6 weeks post natal. Now, the assessment management approach to PEs, like this is the algorithms, the algorithms you all know about. Now, you have a patient that came to you with a high clinical suspicion. You suspect PE from just the clinical uh, symptoms he has. All right. And from the chest x-ray, you see that the chest x-ray is normal. There's no any other disease or possibility. You proceed with the Wels criteria. Now, if you're going to do the Wels criteria, this patient maybe probably stable patient. All right. And then you determine the pretest probability of this patient, and then you assess for hemodynamic stability. Why is that? Because a hemodynamically unstable patient will require another approach. All right, in the diagnosis and in the management of his case. After that, you diagnose. Let's say you diagnose PE. What you gonna do? Before you proceed, of course, you're gonna start anticoagulation. This is of course for all patients. Any patient with PE will require anticoagulation. There is no question about that. But we also gonna have to do what's called risk stratification. We determine the risk or the prognosis. We talked about this before, like when we talked about the PESI score, when we talked about the echocardiography, when we talked about the biomarkers. Determining the risk of the patient will tell us how we're gonna treat this patient and where. Either we're gonna hospitalize, are we gonna send him back home with an anticoagulation only, are we gonna reperfuse, are we gonna activate a catheter lab? All right. And then we're gonna talk about the management of the complications, how to deal with these, prevention, recurrence, chronic complications such as pulmonary hypertension. Now, this is the simplified algorithm. You suspect the patient, you do the Wels criteria, +4, 4 or less, unlikely. Maybe you do PERC in the emergency department, and if all apply, you send him back home. But also, for the exam, they're not gonna ask you about the PERC, of course. If it's unlikely, you do the test. All right, you do the test. It's always available. D-dimer. All right. If it's more than 500, you proceed to imaging. All right. If it's negative, now sensitive test rules out the disease, so this is excluded. In which part? In the P unlikely. If it's likely from Wels criteria, you proceed directly to imaging. All right. All right. What about patients? All right. Let's talk about this one before this one. Patients with hemodynamic instability. A patient with hemodynamic instability with a systolic blood pressure, let's say less than 90. All right. The first thing we're gonna do is echocardiography, transthoracic echocardiography. Why? We're gonna look for a right ventricular dysfunction. Is this hemodynamic instability because this patient right heart is dysfunctional? Is it because of PE? All right. If no, you have to look for any other possibility of shock, infectious, septic, any kind of shock. Doesn't matter. This way we ruled out PE. If yes, in this hemodynamically unstable patient, if yes, CTPA, always CTPA is the gold standard diagnostic measure for PE. All right. But sometimes CTPA is not available. It's not ready because this patient is in a critical state. He is hemodynamically unstable. All right. Now, these algorithms, these criteria, they're new. They're 2020 European guidelines. These are the ones that they're going to ask you about in the boards. All right. So if it's doable CTPA, you do the CTPA, and if it turns out positive, this is PE. You treat it as a high-risk PE. Immediately, this is a high risk because it's hemodynamically unstable patient. Now, this is important, as we said, about risk stratification. We don't stratify a patient with hemodynamic instability. Why is that? Because immediately he is a high risk. All right, we stratify patients who are intermediate. Okay. Again, if it's negative, now it's obviously not PE. You look for another thing. All right. How about if the CT is not available? We can't do CT right now. Just manage it as if it's PE. What you're gonna do? You're gonna have to reperfuse this patient. Try reperfuse him. You just have to think that you suspect the worst possibility. All right, you proceed to treatment. Sorry, we're gonna back to the hemodynamically stable patient without hemodynamic instability. As we said before, you suspect, you do CT in a high probability, or PE likely. If it's unlikely, or you did the probability scores, low or intermediate probability, you do the D-dimer, as you said, negative, no treatment. Positive, you proceed to CTPA. If negative, no treatment. If positive, you confirm, you treat. All right. Risk stratification. Now, obviously, this is gonna be about the intermediate one. Why is that? Because the high and low ones, they're easy. Like a patient, as we said, with hemodynamic instability, that this is a high risk patient immediately. You're gonna see, like, if you're gonna, even if you're gonna do it or you're not gonna do it, the PESI score is gonna be high. The right, of course, is gonna be right with right dysfunction, right ventricular dysfunction, either from the echo, or you can see it as we talked about this in the CTPA. You can see like the heart changes. All right. Elevated troponins, they're gonna be elevated in these patients. A low risk patient is the one that doesn't have any of these. There's no hemodynamic instability. You do the PESI score. The SPESI, the simplified PESI score, is less than 1. It's 0. All right. If without even doing the right right ventricular or you do the echocardiography, you don't have even to do it, maybe, because this patient, maybe if you do even the cardiac troponins, this is a low risk patient. Okay. Now these patients with the PESI score high but no instability. If it's instability, as we said, this is high risk, but no instability, you do the PESI score. Okay. And now in the guidelines, they also let you do the echo. The echo is important in PEs. The newer guidelines, they tell you that the transthoracic echocardiography is really important. Okay. Even if you don't do it, you assume that you already did the CTPA, so you can see this change. As you can see, elevated troponins, right ventricular dysfunction, both of them are present with a high PESI score. Now this is intermediate high. Why is that? Why it's high? What's made it intermediate? Being PESI positive score, it's intermediate. Okay, and without its instability. What made it high intermediate is that both of these is positive. As you remember, we talked about these, like the prognostic. Both of them are present. This is a higher intermediate risk. But if neither of these or only one of them is positive, now this is a lower intermediate risk. Okay, how are we gonna approach patients that already diagnosed with PEs? Now, everyone diagnosed with PEs, of course, you're gonna anticoagulate. You're gonna give DOACs, if not contraindicated, all right? But then, as we said, we have to risk stratify these patients because it's gonna change the way these patients are treated. If it's hemodynamic unstable, this immediately high-risk patient, you're gonna hospitalize and you're gonna reperfuse and you're gonna give a hemodynamic support. You're gonna give a cardiopulmonary support if he needs. How are you gonna reperfuse? We're gonna talk about this. You're using systemic TPA or catheter or surgical. All right, there's no hemodynamic stability. This is not high risk. This is either low or intermediate risk. How are you gonna do that? You're gonna see from the previous table. You're gonna do the PESI score. We're gonna do right ventricular. We're gonna assess the right ventricular dysfunction either from the echo or from the CT, and we're gonna do the troponin. Maybe we do the troponin. Okay. If no right ventricular dysfunction and no positive PESI score, now this is a low risk patient. What we do about the low risk patient? Look, these low risk patients, you don't have to hospitalize. Why is that? Because hospitalization itself increases the risk of thromboembolic events. So if there is any other indication to hospitalize, maybe, like there's no one to care for this patient, all right, and he has like easy access to Medicare, and maybe we hospitalize this patient. But usually early discharge back home, early ambulation, this patient's prognosis is good. He's going to do fine with anticoagulation alone. Okay? But those ones with either right ventricular dysfunction or a positive PESI score, now they're gonna turn out to be intermediate risk. What we're gonna do about this, as we said, we do the troponin test. If the troponin is positive, okay, with the right ventricular dysfunction, both of them, as we said, this is high intermediate risk. If either one of these, like the right ventricular dysfunction without troponin or troponin without right ventricular dysfunction, this is a low intermediate risk. How are you going to manage these? These are managed differently. Obviously, you anticoagulate a low risk intermediate, but with hospitalization. You admit to the hospital. He needs to be hospitalized, all right? Maybe because these ones are going to end up or going to deteriorate, all right? Intermediate high risk, now you're going to close monitor this patient and consider maybe these ones, maybe you can do reperfusion. We don't reperfuse low risk intermediate, but we can reperfuse the intermediate high risk patients because they can deteriorate and become high risk patients. They need close monitoring, all right? Treatment. Now, obviously we've finished, but now we're gonna talk about stuff that they're gonna ask you in the exam. Some pearls about how to manage or how to approach these patients. For example, they ask a lot about stabilization, like in hemodynamically unstable patient. As we said, we're gonna have to stabilize this patient. We're gonna have to give him respiratory support. We're gonna have to give him oxygen. Obviously, are we gonna mechanically ventilate this patient? Probably not. We all know that mechanical ventilation is a positive pressure ventilation. It can worsen the hypotension, okay, and it increases the right ventricular pressure. It's not a good idea to mechanical ventilation, but it's good idea to oxygenate these patients. Fluids, we're gonna give IV fluids, but also again we're gonna be conservative about these fluids we give, and it's up to ECMO. They can, as you said, in the case of supermassive PEs, they can be like severely cardiopulmonary failure, and you're gonna do veno-arterial ECMO. You give cardiopulmonary support. All right, high probability or delayed imaging patients. Now, this is a high pretest probability patient from Wels Criteria. Or you can do imaging. Now, the boards ask you this question all the time. What you gonna do? What's the best next step? You're gonna start anticoagulation. This is the first step. You're not gonna wait for this patient to run up into another PE that's gonna die from it. You're gonna start anticoagulation immediately. If it turns out that he doesn't have PE from the CT, then you're gonna stop the anticoagulation. But at least we assume the worst outcome, as we said. All confirmed PEs should receive anticoagulation. This is no-brainer. DOACs, direct oral anticoagulants, these are the new ones. They become the first-line choice for anticoagulation. Now, we used to say that it's warfarin with bridging with heparin. Now, it's not. If this is a possibility, now this is the first choice. DOACs, we're going to talk about this later. Now, warfarin is preferred over the low molecular weight heparin as a second line. A hemodynamically unstable patient with confirmed PE will require primary perfusion. We talked about this. A temporary cessation of anticoagulation if thrombolytic therapy like TPA given. Like if you choose, look, for those with massive PE, like large PE, or those with hemodynamic instability, the immediate answer is systemic thrombolysis. TPA, giving TPA. But during that time, you're gonna need to stop the anticoagulation. All right, and maybe we give like only like unfractionated infusion heparin. A direct catheter thrombolysis might be preferred over systemic thrombolysis, in which cases in stable massive PEs. Now, why is that? Now, it's still the answer is gonna still be TPA, but they're not gonna let you choose between, let's say, catheter-directed thrombolysis and TPA. All right, because they both do the same thing. All right, they're the same thing. It's just like, you know, like what you're gonna eat for today. At the end, you're gonna eat. All right, but maybe like something is a bit better and it's sweeter than the other one. Okay, so this is the same case. This is a catheter-directed thrombolysis. Like you give the thrombolytic agent locally, right into the thrombosis. All right, with a catheter. Now this is gonna be obviously with much less TPA, because it's giving locally focused smaller doses, so the risk of bleeding is much less. This is it. But still, it's still the answer for unstable or massive PEs. It's TPA. If it's stabilized, maybe in real life, doing it the catheter way is better than giving it IV. Thrombolytics contraindicated. If thrombolytics are contraindicated, or you pass the window to give TPA for PE, it's 24 hours from starting of the symptoms. If the patient came after 24 hours from starting of symptoms, there's no use to give TPA. Okay, you prefer a catheter embolectomy. Same thing when it's if it's contraindicated. Primary perfusion, thrombolytics are contraindicated for bleeding problem. You do catheter embolectomy. The catheter way, now it's done. The surgical one is becoming less favorable. All right. IV C filters, infusion cable filters. Now, this only is in one question. If it's gonna say like anticoagulation is contraindicated, okay, you can't give anticoagulation. All right. What's your choice? You're gonna do a filter to prevent PE, recurrent PE. Okay. The other one they talk about is that there's recurrent VTEs despite adequate anticoagulation. I mean, it's not really what's done. You can give like another form of anticoagulation. You can increase the anticoagulation. There are better choice. I mean, these IVC filters, they with time they thrombose. They themselves embolize. They go and perforate your pulmonary artery, and they go all over the lung and stuff. It's crazy. Chronic thromboembolic pulmonary hypertension. Now, the treatment for this chronic condition is surgery. Which type of surgery? It's pulmonary thromboendarterectomy, vascular surgery. For how long are you gonna anticoagulate? Now you're gonna have to learn these terms: provoked versus unprovoked PEs, or provoked versus unprovoked DVTs. Now, simply, a provoked, like there's a reason that this happened. Like there's a specific risk factor. He had this recent surgery. He had a long flight with. He's got like hypercoagulability disease. You know, any provoked surgical or medical problem that led to this venous thromboembolic event. Now, unprovoked obviously has no reason. So the recurrence rate is higher because we don't know what caused this. All right, we don't know. Maybe what made it come this first time. Maybe it would come. It will reoccur now. And this is the actual. This is actually what happens. I mean, unprovoked PEs, they tend to reoccur a lot more than provoked PEs. So the treatment for unprovoked PEs is indefinite. Now, indefinite doesn't mean for life. All right, and it doesn't mean like a specific time, like a year or two. maybe it's indefinitely. We don't know for how long. You're probably going to stay very long time on this. Provoked, this is a specific answer, at least 3 months. Now in real life, this is spectrum, like maybe it depends, like the risk is mild, only like mild risk factor, or provocative disease, maybe 3 months, maybe 6 months, maybe a year. It depends. All right. So unprovoked PE means that there is no clear risk factor, such as recent travel, surgery, trauma, that caused the clot, and there is a higher risk of having another blood clot in the future, the risk of recurrence. Now, which risk factors that will require longer duration for the provoked PEs? Which provoked PEs? We said it's at least 3 months, but there are specific ones that usually give more than 3 months. For example, active cancer, right? You're going to give probably for more than 3 months, maybe 6 months, maybe a year. Antiphospholipid syndrome, right? Recurrent VTEs, like a second, a third one, you're going to anticoagulate for a longer time, all right? Even if it's unprovoked. Anticoagulation should be stopped for 2 weeks in cases of major bleeding, then resume. Now, this is a question sometimes they ask in the boards, like they're going to say, all right, this patient had GI bleeding and then he did a surgery. Obviously, you're going to stop the anticoagulation before that. So after that, for how long this patient needs to be off the anticoagulants? When you resume, when do you restart? 2 weeks. After 2 weeks, you resume the anticoagulation. You have to balance between the risk of bleeding and the risk, of course, of another thromboembolic event. Now, these the worst recurrence can occur with the unprovoked VTE. Okay, as we know, higher recurrence rate. In the second one, more than the first one. A first unprovoked is highly likely to recur more than non-surgical provoked VTEs. The non-surgical problems more recurrent than the surgical problems. The non-surgical ones, the ones we said here, like active cancer, antiphospholipid syndrome, recurrent VTEs. The men more than women throughout all life. Now, this is not to confuse with acute coronary syndrome. In acute coronary syndrome, the men have higher risk than the women until the women have menopause. After that, they are equal. But in PEs or VTEs in general, the men have more recurrence rate than women throughout the whole life. Cancer patients have a higher risk. The site of the origin of the thrombus, the DVT, the more proximal it is, the higher recurrent rate than if it's distal. If it's in the left side more than the right side, as we talked about in the May-Turner syndrome. Prevention. When do you prevent? Or how do you prevent? You usually give, for low risk patients, as we said, early ambulation. Let them move quickly. Don't just let them stand there and clot more, maybe. Sometimes they especially for DVT, they have these, they're thinking about, oh, maybe we're going to move the clot, and it's not. For low risk patients, just early ambulation is better. Okay. Sometimes you're gonna give low molecular weight heparin, Fundaparinax for the general surgery patients. Some patients in surgeries, it depends. And the surgeon decides that, of course. I mean, if it's gonna be a long time after the surgery in the hospital, of course you're gonna have to anticoagulate to prevent, not to treat, to prevent the occurrence of VTEs, even in patients that they don't have a risk for PEs. All right. Now the new ones like DOACs, the rivaroxaban, and the others, they're not approved for the other surgeries, and only approved for the orthopedic and spinal cord surgeries. Okay. direct oral anticoagulants, DOACs, rivaroxaban, apixaban, edoxaban, they all XA ban. They ban the XA factor 10 inhibitors. Right? Dabigatran starts with the D, direct thrombin inhibitor. All right? Time to peak. It's not that important. Half-life, very important. Now, as you can see, the time for the level of this drug to cut in half is low. That means you're gonna run out of the whack very quick if you miss a dose. Okay? If you miss a dose, you're gonna have an increased risk of clotting, of thrombosis, of embolism. Okay? So we have to ensure that this patient has a good compliance to these drugs. The bioavailability with rivaroxaban is higher, much higher if given with food. You have to give rivaroxaban with food, with eating food. Okay? Absorption. They're all absorbed in the small intestine proximally. So you can imagine that why we mentioned the place of absorption is important, because nowadays they talk about the gastric bypass. In a patient with a gastric bypass surgery, you bypass the duodenum. So like these absorptions, they're gonna be affected. So maybe it's not a good choice to give DOACs in patients with gastric bypass surgery. All right. Renal excretion and dosage. As you can see, rivaroxaban and apixaban, you start them immediately. You just give them right now. They peak at 3 hours, and all right, they peak at 3 hours. They start working immediately. 3 hours, and they're in your system working and anticoagulating your blood. Okay, you give 50 milligrams for 21 days and twice. All right, twice, and then followed by 20 milligram once. So as we said in the early weeks, the risk is high, right? So we give a bit higher dose, and then we decrease it to for rivaroxaban, it's just it's gonna be like 20 once daily. For apixaban, you start with 10 milligrams twice daily, and then after 7 days, you give half the dose. All right. Edoxaban and dabigatran, it's just the same thing with the others. But why we don't just give them from the start? It's just the studies did it this way. In the studies, they approved the edoxaban and dabigatran. They started these agents with parenteral agent with heparin, for example. All right, for 5 days, and then switched to edoxaban and dabigatran, because they said like, okay, we're gonna be like safe, and then we start with something we already know about, for these patients. We're not gonna give them that risk of starting immediately with these drugs. So in first 5 days, they only gave a parenteral agent, heparin, for example, and then starting from the 6th day, they stopped the heparin and gave edoxaban and dabigatran. Now this is different from what we call bridging in warfarin. In bridging, you give both of them, and then you stop the heparin and you continue with the warfarin, because it has increased risk of thrombosis in the first few days, okay, related to increased protein CNS. All right. So in edoxaban and dabigatran, this is different. This is not bridging. This is switching. Okay. Why is that? Because this is how they did it. They were very cautious in these patients that they did the studies with. Considerations. What's the contraindications for anticoagulants? All right. Creatinine clearance is low. They're renally excreted. All right. Hepatic disease. You don't give them, obviously. All right. How are you going to measure the level of these drugs? Is there a way? Yes. For these ones, for the factor 10 inhibitors, you measure the anti-factor 10. For dabigatran, you measure the thrombin time. It's not available everywhere. I mean, it's hard to. I mean, we don't do that actually. We don't measure these levels. Like, is the patient is good? What's the level? Is it fine? Is the drug, are the drugs are doing fine? I mean, we know that these drugs, we don't have any way to measure these. We don't do INRs. We don't do PTs or PTTs usually we can do them, but they're not that good in telling us the level. Now these are good, but are they available? That depends. So you basically gonna be anticoagulating blindly, actually. All right. The reversibility. There used to be no reversal agents for these ones. Maybe sometimes for some patients you don't choose that because you're discussing this with the patient. He says, all right, I'm afraid if something happens, maybe we don't have other choice than giving you, like, for example, a prothrombin complex, or we give you plasma anyway. Now they have these ones if available. Factor inhibitors are blocked with andexanet, Andy, factor 10.net. All right, that's how I memorize it. For dabigatran, Dabi, looks like a girl's name. Ida, also a girl's name. Ida Rusi, maybe she's from Russia. And then this is the monoclonal Zumab. Ida Rusi Zumab. That's how I pronounce it. Andexanet for the 10 inhibitors. What's the best choice of anticoagulant? Obviously, not everyone is going to be like on DOACs, even if they're first line. For example, contraindications like renal disease, you can't give low molecular weight heparin. You can't give DOACs, you give warfarin. In liver disease, you can't give warfarin, you give low molecular weight heparin. In coronary artery disease, we're going to talk about this in the cardiovascular system. Rivaroxaban, apixaban, doxaban, they're good, they're fine. In bleedings, especially GI bleedings, apixaban has the least GI bleeding index. So apixaban is preferred over the other DOACs in GI bleeding. In general risk bleeding, ischemic stroke patients, general bleeding, elderly patients, dabigatran is better, right? Dabigatran. Also, apixaban is a good choice. In pregnancy, we talked about this, low molecular weight heparin. In fat people with fat or high body mass index weighing more than 120 kilograms. Now they talk about, like, if you're gonna measure the levels and you're gonna like increase the dose of DOACs, and then that's fine. But usually we don't do that, as we said. We can't measure the levels. So what are you gonna do? You're gonna use warfarin. Okay, warfarin is better in these people. Gastric bypass, we said about this. We can use DOAC. We use warfarin. Thrombolysis, we talked about that. And availability of reversal of agents, we go back to the old days and we use warfarin. Cancer patients, now this is a very important question. The use about cancer patients. Now the studies are ongoing still. They talk about using DOACs with cancer, and sometimes they're not used. So far, the DOAC that's promising for the use with cancer patients is edoxaban. Soon maybe it's going to be approved. But so far, the first line for cancer patients who require anticoagulation is still by far low molecular weight heparin. Poor compliance, also we go back to the old days, we use warfarin. So DOACs are contraindicated also in a mechanical heart valves. A patient with a mechanical heart valve, you give warfarin, all right? And we're going to talk about that in the cardiovascular, why is that. And in severe renal and hepatic failure also, we talked about this because they have increased bleeding risk. Now, for monitoring, as we said, PTT and PT, they're not that reliable. But in studies, they said like a PTT is more sensitive for the direct thrombin inhibitors, for the dabigatran, all right? But the PT is a bit more sensitive in measuring like how good is the factor 10 inhibitors are working, all right? Warfarin, they inhibit factor 10, 9, 7, and 2. you start same day with heparin together. That's the bridging, at least for 5 days, and until the INR is therapeutic. What's the therapeutic INR? Is about 2.5. All right. Warfarin skin necrosis. Then this can occur sometimes when like the patient has protein C or S deficiency. What are you gonna do about this? You're just gonna start with a small dose and increase gradually. Thrombolytics, we talked about this. Like the most common one we use is TPA, streptokinase, maybe allergy, maybe urokinase, and then these ones they can be administered, as we said, systemically or through a catheter. Okay, and the catheter is less bleeding than the systemic because you're gonna use a much lower dose. Now, the contraindications for thrombolytics: CNS bleeding, internal bleeding. You can read that. It's just anything that causes bleeding. All right. So in summary, VT is one of the most leading causes of deaths in the world with an increasing incidence. They say in 50 years or maybe until like 2050, it's gonna be doubled. PEs are gonna double. But luckily, the mortality rate is less because we have now better choices with anticoagulation. VT can lead to right heart strain and chronic pulmonary hypertension. Wels criteria is still the preferred criteria to determine the pretest probability in the diagnosis. D-dimer is highly sensitive test. That's good to rule out, as we said, SNOUT, sensitive test, for low and intermediate probability PEs. Risk stratification is essential in determining the best treatment of acute PE. Echoechocardiography and troponin levels are part of the risk stratification, all right, and determining the risk of this patient. CTPA is the best imaging modality for PEs. EKGs are non-specific, as we said, but they can be helpful when the other causes are ruled out, and we consider PE. Early anticoagulation with the highest PEs, all right? Yes, so this is two parts, like early anticoagulation with high risk PEs, okay? Or we said also if you can do CTPA and primary reperfusion in massive with usually systemic thrombolysis, TPA, in massive and hemodynamically unstable pulmonary embolisms. DOACs are now the first line choice for anticoagulation, and we consider the specific scenarios we talked about in the table. And unprovoked PEs have higher recurrence rate, so the treatment can be indefinite, right? And for provoked PEs, we said at least 3 months. All right. Thank you for listening, and until another lecture, see you.